Well, good afternoon and welcome everyone to this talk on tuberculosis. You see, we are going to have two talks on this. First is the diagnosis and the related issues, and then subsequently treatment, etc. So please feel free to interrupt me as in when you need. You see, it is a kind of informal discussion. I'll just give a brief introduction to tuberculosis. I'm sure you already know about it because this is one disease from which one cannot escape, you see. Whether you are an MBBS doctor or MD or DM, wherever you are practicing this, and this is perhaps the most ancient disease, you see. For almost 5,000 years it is known, with different names: consumption, wasting, phthisis, yakshma, king's evil, etc., and so on. You see. So it is caused by mycobacterium tuberculosis that was, of course, discovered only in the 19th century, and it is an airborne infection which spreads by aerosols. You see. Okay, what is it? And it is described in different civilizations by different names. I won't go into these quotes, you see, but I think it is interesting sometimes to read that the people were aware of its infectious nature even in the BC era, you see, in whether you talk of the Indo-Aryan kind of civilization, the Egyptian, the Chinese, and most civilization, it is known by one or the other kind of name, and a stigma was attached to the disease from the very beginning. The modern historical marks, of course, the tubercle bacillus was discovered in 1882 by Robert Koch. You know, I think that is one of the landmark discovery in modern pulmonology, and this is what changed the, in fact, health scene of Europe, you see, and the whole world. And the other remarkable discovery was the X-ray discovery by William Rontgen. Although X-ray was multiple purposes, but it was primarily used for the diagnosis of tuberculosis. And then, of course, the developments took place. BCG was discovered, and chemotherapy drugs, streptomycin, PAS, and tuberculosis burden in India is very high. Almost 1/3 or 30% of cases, 27% of the world's 10.4 million new cases, and 29% of deaths are attributed to tuberculosis in India, in fact. So India is one of the largest burden countries, you see. And the 8 countries, you see, they like India is one, of course, perhaps the largest burden, then Indonesia, China, Philippines, Pakistan, and several other countries, you see. The Indian TB incidence for the year 2021, which is the most recent data available, 210 per 1 lakh population. I think that is an important figure. Earlier it was high, but now with consistent efforts at TB control, the incidence has gone down, you see. And then the other important thing was, in fact, when we were taught at that time, said that nutrition does not play any significant role in tuberculosis. But now the WHO report says a crucial role of nutrition. In fact, now the tuberculosis control program or tuberculosis elimination program includes nutrition as one of the important component of treatment. You see. The present concerns, of course, besides the incidence, are the drug resistance. And drug resistance could be mono-drug resistance, multi-drug resistance, or extensive drug resistance, you see, which was some time back, this was very much kind of discussed all over the world when some cases were reported from Mumbai, the total drug resistance, which they call. The fact is that resistance is an important problem, and then there are co-infections like HIV infection and tuberculosis in immunosuppressed conditions like cancers, leukemias, diabetes, and pneumoconiosis, and so on. And nowadays, of course, latent tuberculosis is also an important issue. Because they say if you can control latent tuberculosis, you can eliminate tuberculosis completely. I think normally this is a kind of balance which is maintained, what we call as homeostasis, that there is a pathogen and there are host defenses. The body defenses are there, then normally a kind of a balance is maintained. Whenever the pathogens become heavier, the infection occurs, you see. That is a kind of old fact which was Louis Pasteur and Robert Koch. They discussed in detail about this balance, you see. So whenever there are more risk factors, the immunity goes down, and these are important. Some of these I have already mentioned: malignancies, leukemias, lymphomas, other immunosuppressed conditions, patients on corticosteroids for one or the other disease. HIV infection is an important risk factor. A negative patient has the risk of 5 to 10% in his lifetime, you see, while a positive patient has almost 50% risk of developing tuberculosis. And they say in lifetime, almost all patients will develop tuberculosis, you see. Then malnutrition, the drug abusers, psychiatric disorders, close contacts of patients are also identified as important risk factors, in particular the infants of sputum positive mothers, you see. Then people living in poverty, slums, crowded areas, alcoholism, tobacco smoking, and other comorbidities like diabetes, etc. They are also important risk factors for tuberculosis. So those were the risk factors for development of tuberculosis. Then tuberculosis activation, you see, not much difference between tuberculosis activation implies that person has been exposed to tuberculosis in the early childhood. So whenever there is any other kind of risk factor, the tuberculosis activation can occur. For example, things like you see treatment with the anti-tumor necrosis factors, sometimes even steroids and other immunosuppressant drugs, patients of kidney failure receiving dialysis, and other things, you see. Then whenever the immunity goes down, the chances of tuberculosis become very high, you see. So now we know that tuberculosis is an infection caused by Mycobacterium tuberculosis. It is airborne infection, spreads by aerosols, enter the lungs through inhalation. Then there is an interplay between the bacillus and the host defenses. So once there is an establishment of infection, the lesion in the lungs or lymph nodes, and sometimes when the GIT can also occur, primary lesion, you see, then it spreads to the other sites. It has been worked out that the multiplying bacillary infection, one bacillus within 24 hours is duplicated to 2. In 10 days it becomes 5,000, and 5,000 bacilli can form a nodule. Within 1 month, you see, it can develop into more than 1 billion number, you see, and that is enough to form a large cavity. So we can naturally anticipate here that one single bacillus entry within a month can develop into a big cavity, you see. And it has also been worked out that one sputum positive, untreated, undetected case can infect 6 to 12% in his first year, if it is untreated tuberculosis. And he can infect up to 24 persons in 2 years. So it is a kind of infectious disease which goes on spreading in the community. That's why it is important to catch them early and treat them. So this is the kind of sequence that there is a risk factor, exposure occurs, and then immediately there is a latent tuberculosis infection which gets set in. And then subsequently, whenever the risk factors get aggravated, latent tuberculosis may become may develop into active tuberculosis. So exposure, latent tuberculosis, active tuberculosis. So that is kind of sequence which goes on, you see. So that is the first stage, which when there is inhalation of bacteria, the airborne droplets into the respiratory tract, and then they settle into the airways. There is engulfment by activated macrophages. So these are the defense cells in the body which engulf the microorganisms and mycobacteria, the dendritic cells, the macrophages, and these are the cells which transform into Langerhans giant cell, you see. So that is the first stage of infection, and subsequently there is replication of Mycobacterium tuberculosis. The cells which have been infected, they burst, they release the mycobacteria, enter into other cells. So that kind of infection goes on multiplying within the body, you see. And subsequently there is T cell activation, initiation of cell mediated immunity. You all know that is a kind of tuberculosis is mediated by the cell mediated immunity, and there is migration of activated T cells. Then by now there is formation of granulomas, and this is what is called as a primary lesion, or the Ghone's focus sometimes. So this is involvement of, in a way, parenchyma and local lymphatics and lymph node together. So all three components they get involved. Liquefaction of granulomas can occur in primary tuberculosis and spread through lymphatics. It can spread to other organs through lymphatics or blood to bones, liver, spleen, and GIT. Otherwise, they remain dormant, hidden in the lymph node, which is kind of delayed cell immunity. So that's what I have already said, that there is a primary infection, that there is a formation of local caseation, Ghone's focus, and then it gets healed. So that is a healed tuberculosis. Many of the exposed people, especially in this country and other kind of countries where tuberculosis is high, that is the common sequence, you see. But it can develop into latent lesions, and it can reactivate into tuberculosis, secondary tuberculosis, or it can primary complex in an immune deficient patient can progress to progressive primary tuberculosis, Milroy disease, and so on, and then it can the secondary tuberculosis. So it may once there is infection, it can either go progressive or healed. That is one kind of sequence, or it can progress, and then, or it can latent lesions, they can remain latent, but subsequently they can get reactivated when there is a kind of secondary tuberculosis, and then there is a progressive secondary tuberculosis. So all forms of tuberculosis can occur in one or the other ways. Latent tuberculosis is very important and the focus of government focus on treatment, because there is a pressure from the international communities, the WHO and so on, that you must treat latent tuberculosis. In India, so far, latent tuberculosis was not the preference of treatment, you see, because most of us are or have suffered from latent tuberculosis and nobody takes treatment. So it is a state of persistent immune response to stimulation by MTB without evidence of clinically manifested active tuberculosis. That is important because in this country, until now, it was only active clinical tuberculosis which was treated. And initially the WHO guidelines also were different management. You see, I think we daily see people who are Mentus positive, or there is a calcified focus in X-ray, and these people are not issued visas by foreign embassies, and that is a very important issue which has become that they are very afraid of taking even healed or latent tuberculosis in their countries. In India, we pass on kind of, so perhaps in future we will be treating more and more latent tuberculosis as well. So just briefly, the pathology, you know, there is a kind of Ghone's focus, there is caseation in the center, then there are lymphocytes around it and Langerhans giant cell, etc., and epithelioid cells. We need not go into further details. The most important is how to diagnose tuberculosis. Diagnosis of tuberculosis is a kind of a multifaceted issue. One is microbiological diagnosis, which is smear positive for acid-fast bacilli, one or more, or culture positive. Ideally, it should be culture positive, but for routine purpose, we consider it as smear positive. So that is the definitive diagnosis. Immunological or molecular diagnosis can be made, histological or cytological, and finally clinical and radiological. So it is a decreasing kind of order of preference, you see, or we'll come to these things soon. Some of you would remember the Koch's postulates, you see, the Robert Koch, when he discovered mycobacterium tuberculosis. At that time, the microbiologically, they say it can be called infection only when the organism is found in each case of the disease. It should not be found in other diseases, so that it is highly specific. It should be isolated on culture. It should be cultured. It should, when inoculated, produce the same disease in other persons. You see, that is the transmissibility. And it should be recovered from the inoculated animals. In the past, in fact, guinea pig inoculation was a test employed in clinical practice to diagnose tuberculosis. Nowadays, of course, it is no more done. It is only for the research or laboratory animals. So we can say that the level of diagnosis of tuberculosis can be three: suggestive, presumptive, and definitive. These are the three levels of diagnosis. Suggestive is possible. It is on clinical suspicion, for example, blood in the sputum, prolonged fever, coughs, sputum, weight loss, weakness, malaise, and high prevalence areas, you see, or a presence of a risk factor. However, it cannot be considered as definite because there are other causes of all these symptoms, you see. There are multiple causes. But certainly it is suggestive. Then it is possible when there is radiological evidence, probably indirect evidence is there. For example, there is infiltrates in the lung, cavities in the lung, miliary shadows in the lung, or histopathology showing granulomas, or some markers like the pleural fluid. You can have kind of different proteins, exudative effusions, and so on. Occasionally therapeutic response, although that patient is empirically given ATT and respond. So this is not a good evidence for diagnosis. Most important is the mycobacterial demonstration. You see that you have to demonstrate preferably on culture, but for routine purposes even smear is good enough. You see. So it is not only in sputum, one can demonstrate in other specimens if possible, but sputum is the most likely. Syndromic diagnosis, I have already discussed that there are kind of clinical features: pulmonary foci, lymph node enlargement, pleural effusion, miliary shadows, fibrocavitary disease, etc., etc. And then there could be extra-pulmonary. I think extra-pulmonary tuberculosis is assuming more and more importance. Extra-pulmonary means other than the lungs, you see, that lymph node, bones, joints, abdomen, liver, etc. And sometimes it is disseminated, means miliary tuberculosis, when more than one organ are involved. So this is the kind of radiological feature: chest, upper lobes mostly. Sometimes it can be diffuse, infiltrates, exudates, fibrosis, thin-walled cavities, miliary or lymphadenopathy. But please keep in mind that no chest X-ray is absolutely typical of tuberculosis. 10 to 15% culture positive patients are not diagnosed by X-ray. That is another thing you see. So X-ray is not always present. 40% of patients diagnosed as having tuberculosis on the basis of X-ray alone do not have active tuberculosis. Because nowadays we know that there are many other causes, granulomatous diseases, pneumoconiosis, and even other infections, fungal infection, etc. can cause it. And sometimes CT chest is done, especially for miliary tuberculosis, mediastinal lymph nodes, pleuropericardial effusions, and sometimes the hidden lesions are there, occult lesions behind the heart, behind the sternum, behind the ribs, and so on, you see. And similarly, X-ray is unreliable for diagnosing as well as for monitoring treatment. You see, you cannot just, based on the response on X-ray, say that the patient is responsive. So this is some of the X-rays. For example, you can see here that both the upper lobes show infiltrates and some fibrous lesions. Another X-ray showing fibrocavitary kind of middle lobe lesion on the right side. Sorry for the poor projection, but anyway, it is again cavitary tuberculosis, infiltrates, cavities. Lymph node enlargement, and then cavities there in the apex. You see. Seeing fibrosis, cavitary disease. But as I said, you cannot necessarily say that it is tuberculosis from these X-rays, you see. That is tuberculosis. This is miliary tuberculosis. You can see small kind of millets spread all over the lungs, you see, with small miliary nodules. This is the mediastinal tuberculosis. I think the X-rays are not really projected well here. Anyway. I've just put one slide on ESR because ESR is frequently identified to say that it is tuberculosis. That was so in the past. Now we know that ESR indicates inflammatory activity. As a standalone test, it does not really help to make a diagnosis. It only tells that there is active inflammation going on. And in all infections, inflammations, it can rise, you see. Other bacterial infections, viral infections, so inflammations, non-infectious inflammatory conditions, connective tissue disease, systemic lupus erythematosus, rheumatoid arthritis, etc. It can all cause. Even in non-inflammatory conditions, it can be high. For example, if there is anemia, it will be high, you see, because the erythrocytes are low. Now comes the Mantoux test, you see, which is most commonly identified as a test for tuberculosis, especially amongst the lay. And you know, this is a subcutaneous or intradermal injection of tubercle protein, and it causes kind of reaction, you see, induration, and redness. So how to interpret Mantoux test? If there is induration of less than 5 mm, it means there is no exposure to tubercle bacilli. 5 to 10 or 5 to 9 can be due to atypical mycobacteria, BCG vaccination. It may suggest infection in immunocompromised patients. So it's a mildly positive in a way Mantoux test 5 to 9. If it is more than 10, it is it means tuberculin sensitivity. We call as tuberculin sensitivity. Some people say it is tuberculosis or latent tuberculosis. Important to understand scientifically is that it denotes infection. There is a difference between infection and disease. You see. Infection means whenever the microorganism enter the body, it causes infection. It is an infection. But it does not mean there is a disease presence. You see. Disease is when there is a body reaction and it is causing other symptoms of problems. Okay, so Mantoux test indicates only infection, that patient has been exposed to tubercle bacillus. It does not differentiate between infection and active disease. If it is strongly positive, for example, we have said here 10 millimeter or more, it can support a clinical diagnosis. But they say it is the negative test has better value than the positive test, because negative test almost excludes tuberculosis. Although that is not always true. For example, if a patient is immunosuppressed, it may be negative. If a patient has serious disease, it can again be negative. You see. So negative test has some conditions, but otherwise it is more specific to exclude tuberculosis. And the other thing I will insist here is the induration is what is more important. You see, it is not the redness. Redness is just change in color. Induration is when it gets infiltration into the skin. You see, there is hardness kind of. So after Mantoux test, the other is the mycobacterial demonstration, which can be done most commonly in sputum, sometimes induced sputum. In children, gastric lavage has been used. Pleural fluid can be examined. Other extra-pulmonary specimens, fluids like ascitic fluids, even CSF has been biopsies. Fiberoptic bronchoscopy can be done, and you can see the ulcers in the bronchial tissue, and you can get bronchoalveolar lavage to test the AFBs. You can do biopsy, etc. So all these are samples which can be tested depending on a particular situation. Smear examination is the easiest and quickest, you see. But the only problem is it requires at least 10,000 AFBs per ml to have a positive smear test, sputum smear test. Its sensitivity is 50 to 60%, but specificity is high, which means if it is positive, that means it's likely to be tuberculosis, most likely to be tuberculosis, or negative is almost no tuberculosis. Culture can be positive in the presence of even small number of bacilli, 10 AFBs per ml. But it takes longer time, 6 to 8 weeks. Other methods are there, septi-check, biphasic, etc., radiometric or Bactec assay, and other mycobacterial growth indicator tubes. So these are more kind of advanced and recent tests which are available, and the results are available quickly by other methods. This is the standard solid culture. You know the Lowenstein-Jensen medium, which is a solid medium. It takes longer time. Then of course we have the molecular test, DNA based test, and antimicrobial sensitivity. Nowadays there is also the mycobacteria can be directly tested from the clinical samples. You see that you don't have even prepared smear, or you don't have to culture. Just take sputum, take in the tube and test it. That is done with the help of genotypic methods, polymerase chain reaction and its variation. And again there are multiple tests which are available. We don't go into the details here. phenotypic methods are available, but we'll come to the gene expert just soon. You see. Then there are indirect tests, which are markers of tuberculosis, but not always diagnostic of tuberculosis. Which are indirect tests? Biochemical. You know, you must have examined pleural fluids, you see, like pleural fluid for LDH, proteins, adenosine deaminase, bromine partition test, gas chromatography for other things, you see. Again, although we many times consider them as diagnostic, but that is in the absence of a more definite test. If you have more definite test, then it is better to use that test. Otherwise, sometimes indirect tests are used in clinical practice, and we also use immunodiagnostic tests like skin test and IGRA test, you see, which is again indirect test. Then there is detection of antibodies, serological tests. Again, I think that I won't go into the details here because they were banned in 2012, you see, because they were highly misleading tests. At that time, people relied on these serological tests, ELISA positive and so on, antibodies positive. But mycobacteria do not produce any antibodies. I think that is an important fact, you see, which we all know. Therefore, the presence of antibodies or on positive ELISA test, they have no value. So the government banned it so that they do not mislead the people. The second important test is the interferon gamma release assay or IGRA test, you see, which is very commonly employed nowadays. It is an alternative to TST. TST is tuberculin sensitivity test or Mantoux test. It is a kind of in vitro T-cell based assay, test tube TST. People sometimes say it is a test tube TST. It is just like a Mantoux test, except that you do it in the test tube. What is done here is the T cells of individuals sensitized with tuberculous antigens, they produce interferon gamma when they re-encounter the mycobacterial antigens, you see. So if patient is sensitized, then he will produce the interferon gamma whenever there is mycobacterial antigen, and then it would be positive kind of interferon release assay. Initial IGRAs used as PPD as the stimulating antigen. Nowadays they use other antigens, you see, like ESAT, CFP10, etc., etc. And if with the help of these in the blood of the patient or the patient to be tested, there is a high production of gamma, interferon gamma, that means patient is likely to suffer from tuberculosis. This is the kind of forest plot that IGRA in active tuberculosis. It is a very high sensitivity. You can say multiple studies here, and the sensitivity is almost 95%. Different studies have used kind of these are very high figures most of the time, and pooled sensitivity is 75%. So in a way, if it is positive, then there are good chances that it is active tuberculosis. It can also be IGRA is also tested for latent TB infection. In the absence of gold standard for diagnosis of latent TBI, the sensitivity and specificity cannot be directly estimated. IGRA have high specificity than TST. I think that is the comparison with the Mantoux test, that IGRA is more specific and it has a better correlation with surrogate markers of exposure. It is less cross-reactivity. The skin test or Mantoux test has a lot of cross-reactivity of the other antigens like BCG vaccination. If a patient has been given BCG vaccination, Mantoux will be positive, but the IGRA may not be positive at this. So it is a sensitive, and people are therefore employing more and more IGRA test instead of Mantoux test. Then the diagnosis lastly is that you can demonstrate the mycobacterial components. That the mycobacteria are not identifiable. You just see their footprints. It's just like a thief has come and gone, but there are some other things which are left there, you see, from which you identify that there was a thief, that there was mycobacteria. Here you can do antigen detection with the lipo-arabinomenin, nucleic acid probes can be used, polymerase chain reaction can be used, and ligase chain reaction. So these are all antigen detection tests with the help of genetic and molecular techniques. Most important these days is gene expert. Then there is detection of DNA specific base sequences, DNA amplification and detection. And a complicated and difficult test is gamma RNA. If you have positive RNA, gamma RNA, that is almost diagnostic of multiplying infection, you see. And but that is a bit difficult for the time being. What is gene expert? It is a detection of mycobacterial directly from the clinical samples. I was just talking from the sputum for that. Most important is sputum. People are also doing it in pleural fluid and lymph nodes, aspirates and other things. But the most specificity so far is from the sputum. It has no value from the blood. Okay, it is a cartridge-based PCR test for detection of mycobacteria and rifampicin resistance. That is the additional advantage that it will also tell you about the rifampicin resistance. On-board sample preparation with fully automated RT-PCR amplification and detection. So that is what is that. It is very simple now, except that even it can be done in the remote areas. You see that there is a cartridge is available, sputum is made, and then that is put into the cartridge and put directly into the machine. This was originally developed by Cepheid for detection of anthrax. Nowadays, the test can also be used, of course, for multiple other infections. But most commonly, it is used for tuberculosis. It is a rapid test. Results is available within hours, 4 to 8 hours. Now the time is reduced further. Expanding range of different organisms. So you have to detect the gene for that particular organ using pathogen-specific cartridge. So cartridge is what is most important, and these are made for different kind of bacteria. Multiple modules are also available, permitting multiple assays. Initially, in fact, a few years ago, you could do only one test at a time. Nowadays, multiple can be done. It is a bit costly. Electric supply and maintenance is required, especially in the rural area. Field feasibility remains a question, although now it is by and large taken care of. And it can, whether you can start MD-TB treatment on the basis of rifampicin resistance demonstrated on gene expert, that is a bit questionable. The recommendations of the program is that you should, if it is positive, it is showing rifampicin resistance, then you should send for culture before starting treatment. Because otherwise, many times it is only a wastage of drugs and giving kind of side effects to the patient. It has a good sensitivity, good specificity. I think that is what is more important. Pooled sensitivity in HIV negative patients is also high. In people living with HIV is also high. In smear positive. So basically all conditions the sensitivity is good enough. Rifampicin resistance, I already said that although it amenable to rapidly detect 95% of all mutations in 81B core region of, I think these are the different genes of mycobacteria. So it can detect these genes in the core of mycobacteria, and if these are present, then it is likely to be rifampicin resistance. And these mutations which are present, if present, they indicate the rifampicin resistance. So both these things can be tested simultaneously. Presence of mycobacterium as well as the presence of resistance, you see, rifampicin resistance. And rifampicin resistance is a surrogate for MDR-TB. If patient is resistant to rifampicin, almost 99% of the times he or she is also resistant to INH. And if there is a resistance to both INH and rifampicin, that is a multi-drug resistance tuberculosis. Okay. Again, this is just to show the different kind of sensitivity and specificity in different studies. You can see here very high sensitivity and specificity according to Cochrane review, and very important and useful test. You can see here the comparison of 2 or 3 important tests: liquid culture, and this is the gene expert, and solid culture and microscopy. The red line, you see, it indicates the mycobacterium tuberculosis with gene expert. So it has a very time to detection is very good. Very early you can detect. Almost 90% you can detect within 1 or 2 days. The only better test here is liquid culture, but liquid culture will be positive after some time. And similarly here, this is the time to detection in days, you see. And you can see here that with other tests like line probe assay, and this is the, of course, gene expert, phenotypic drug sensitive test. Again, the best test available is the gene expert. So practically you can say that gene expert is now the test which is most commonly used for diagnosis of tuberculosis as well as for diagnosis of drug resistant tuberculosis. So the benefits are: it increases case detection in smear negative patients, it reduces the time to diagnose and treatment, reduced patient default during investigation, reduces morbidity, mortality and tuberculosis transmission because patient can be made negative early, and there is increased detection and rifampicin treatment of MDR-TB, and there is a reduced need of culture, reduced biohazard. So these are all benefits, but I told you the limitations earlier. Battery operated systems may not be there, sometimes electricity is not there, especially in the rural areas. Calibration is important, and limited range of operating temperatures. I think that is what is cannot operate in very high or temperature, but most of the time indoor temperatures are good enough to see. It detects dead bacilli, not suitable for monitoring treatment response. That is one important thing, so that you cannot use this test as treatment response. If this is positive, it is positive. You cannot do it subsequently after 2 months and say it has become negative. It will not become negative. It may remain positive. So this is just comparison of different tests: microscopic, lead microscopy, lamp, solid culture, liquid culture. I briefly discussed. So most of the time gene expert has all the advantages. Threshold is high, it is present. In fact, if there are 131 bacilli CFUs per ml, it will be positive. Okay, on the other hand, the others are required differently. Liquid culture, of course, will be positive even in the smaller number, but then there are other disadvantages. Turnaround time is very rapid, 90 minutes the results are available. All other tests take days to weeks. Sensitivity is quite high, 90%. Specificity is 90%. Technical expertise is minimal. Practically, you don't have to do anything, just use the cartridge, put these, and then automatically the result will come. So it is even better than microscope. Same is true for diagnosis of drug resistance, that you have the advantages of gene expert. Results are 90 minutes, it will be available, good sensitivity and specificity, no technical expertise, better than microscopy, and can be done in a usual way. Restriction fragment length polymorphism is a very kind of high value test which is used. It is a kind of DNA fingerprinting. To identify, it is used mostly to confirm the source of infection. But if it is present in one person and then it is present in other cultures also, fingerprinting, DNA fingerprinting you do, so it means it has spread from that those mycobacteria. Normally it is not required, it is only done in the research laboratory. Lastly, a few minutes for extra-pulmonary tuberculosis, because that is very important nowadays, although most commonly lymph node tuberculosis, these are the most common. You know that they can be involved both in primary as well as in secondary, in the neck, axilla, groins, and internally in the hilum, mediastinum, etc., etc. Manifestation, they are enlarged, doughy feeling if they are outside, sinus and scar formation can be there, and occasionally painful. And they serve as the sanctuary sites. You see, that is what is very important. You see, the bacteria can remain hidden there. In fact, that's what is common cause of reactivation of tuberculosis later on. And sometimes they may erode the adjacent organ, causing dissemination. Hepatobiliary tuberculosis, it can cause involving kind of gallbladder as well as liver. There could be disseminated miliary spread, tuberculomas can be there, granulomatous hepatitis can be there. Sometimes there is ATT induced hepatitis. We will discuss this later on during treatment part, that how to differentiate hepatitis from ATT induced hepatitis, because this is a very common and important issue in clinical practice. Of course, patient may complain of pain, liver enlargement, etc. Biliary, genitourinary tuberculosis can involve kidneys, and all kinds of manifestations can be there, pain, pyuria, hematuria, flank pains, etc. And I think you will study these in details when you are being taught of a particular organ. But overall, I just have to tell you that tuberculosis can involve all systems, you see, and whenever there is an enlargement of any other organ. All right, so one of the important causes is tuberculosis. Bone and joint tuberculosis is an important site. In fact, this is the most ancient form of tuberculosis, prehistoric, you see. When it is available on autopsies nowadays, even Egyptian mummies were dissected, you see, and they found the lesions there. It has a hematogenous spread, involve the spine and other bones, hip joints, knee, ankle, foot bones, and there can be different types like granular, osseous, cageous, synovial, etc. Joints can be involved, inflammation and fibrosis can, local warmth is there, pain, tenderness, etc., etc. This is some of the, you see, destruction of the bone here, etc. Spinal TB is of course very dangerous. Infection is same in the cancellous bone. There could be cold abscess formation in the spine, local tenderness, pain, and if there is a fracture or vertebral kind of collapse, then there can be paraplegia, paraparalysis, etc. And you have to differentiate from other possible causes. It's commonly called as Pott's paraplegia. I won't go into the details here. Neurological tuberculosis is a common, and meningitis is most common, but it can also be intracranial or spinal tuberculosis. Tuberculosis abscess can be there, and it is a very kind of, especially tuberculosis arachnoiditis or meningitis is a serious problem in children in particular. Different types of radiological appearance can be there, calcified lesions, cavities. And then it can practically involve other sites as well, skin, where there can be chancre, lupus vulgaris, crofloderma, ENT can be involved, laryngeal, ear, nose, throat, pharynx, adrenal, ocular TB can be there. So practically all organs in the body can be involved. How to diagnose extrapulmonary tuberculosis? Principles remain the same, but the problem is that there is no sputum, and other smears are often negative. So the diagnosis of extrapulmonary tuberculosis many times is empirical or on other grounds, you see. So it is difficult to use microbiological diagnosis for start of treatment, for follow-up treatment, endpoint, when to stop it, recurrences, relapses. That's why there is a lot of confusion. In fact, this is the most common. Orthopedicians, for example, will continue treatment for 1 year to 1.5 years, sometimes even 2 years for bone and joint TB. The chest physicians keep on saying them that you don't have to give more than 6 months, you say. But there is no end point. The patient keeps on complaining pain. I think treatment is continued. So there is no microbiological evidence to suggest. We generally go by clinico-radiological, cyto-pathological diagnosis, but histological or cytological diagnosis is not always possible, especially for follow-up. You cannot obtain biopsies multiple times, you see. Invasive procedures are required to obtain tissues, fluids, etc., but this cannot be done all the time. So therapeutic trial may remain, but it should not be used as a modality. Other methods are used, I think, which will be discussed as you go further or read about other specialties, you see. So this is just to kind of chart that if there is lymph node tuberculosis, empirically is on the basis of clinical, that enlargement is there. And so you start thinking that it could be tuberculous lymphadenitis neck. And then you do FNAC. If it shows granuloma, that is normally lymph nodes are outside, so it is enough to start treatment. But best is to find AFBs on FNAC. If you find AFB positive, then of course it is a definite diagnosis. Pleural effusion, again, clinico-radiological or exudative fluid, you can start ATT. More suggestive is ADA positivity or PCR positivity. And the definitive diagnosis would be again on pleural biopsy or AFB positive. Same is true for pericarditis or peritoneum. These are all kind of serous cavities. So here the exudative fluid, ADA positivity is good evidence, but final evidence of course is if you find either on biopsy or AFB positivity. Intestinal, genitourinary, again clinico-radiological, sometimes endoscopic, etc. You can do biopsy, granulomas can be found. If you can find AIV positive, again nothing like it, you see, but otherwise many times you just go by FNAC or biopsy. You see. That is what is the best available kind of tissue. So in summary, I will say that tuberculosis is a disease which affects the mankind since antiquity for more than 5,000 years, and this is the only disease which is there for which evidence is available for the longest period of time in human history. Now we know it is caused by MTB and primarily affects the respiratory tract, pulmonary, but all other organs can be affected. Best established with mycobacterial demonstration. Molecular tests for DNA or other mycobacteria products are also helpful because they indicate the mycobacterial products, kind of indirect evidence, you see. Clinical features, radiological, I have already said repeatedly here that it is not final diagnosis, but sometimes you have to make clinical decisions. Drug resistance and co-infections are common problems, should be appropriately diagnosed for effective management. And latent tuberculosis, as I said, it is important to diagnose, and the treatment strategy for latent tuberculosis is still individualized. There is no recommendation as of the government or the program is concerned, except for some situations, you see, in immunocompromised host or so. I just have 4, 5, 6 questions which I like to discuss with you. So here is a 16-year-old boy complained of fever of mild degree, cough, expectoration and general malaise. Tuberculosis was suspected as one of the likely diagnoses. Which of the following investigations should be helpful to make the diagnosis? And sputum. All right, I think because that's what we have said, it is a very loaded question, because patient is already bringing expectoration. The problem is when they are not bringing sputum. What will you do then? You can try induced sputum. Induced sputum, giving nebulization of saline, you see, they will cough, etc. So, otherwise, of course, because we have already discussed that the Mantoux test indicates exposure. Blood PCR. What about blood PCR? Blood PCR has no value in diagnosis of tuberculosis. One thing you should remember, that the mycobacteria rarely, forever, they don't go into the blood. The spread is mostly lymphatic. In fact, that's why we don't do blood culture or blood tests, you see, because they do not go through blood. So all these tests which are done from blood PCR, they are misleading. Okay? Blood mycobacteria can be positive only in a very advanced HIV patient, you see, or very advanced malignancy when the immunity is totally depressed, gone. Otherwise, blood, okay? So you keep in mind that blood PCR has no value in diagnosis. X-ray, of course, X-ray and Mantoux test, they are kind of indirect tests. They can be helpful if sputum is not available. Tuberculin skin reaction is elicited by one of the following components of tubercle bacillus. Which one? Long chain fatty acids, protein, polysaccharides, arabinoglycan. Yes? Anybody? Polysaccharide. Which of the component elicits antigenic response? Proteins. ठीक है ना, ये these are carbohydrates. Long chain fatty acid, polysaccharide is a carbohydrate. So these are present in the cell wall, A, C and D. Okay, it is the protein component which is present in the mycobacterium, in the mycobacteria. Here is again a 16-year-old boy who complained of fever, mild degree, cough, expectoration and general malaise. Mantoux was positive, but sputum smear and blood PCR for mycobacteria were negative. Chest X-ray showed a few infiltrates in the right lung. So what will you do now? It is almost a first patient which we discussed, except that now more investigations are available. The Mantoux was positive, sputum were negative. So what will you do? One is to start anti-TB treatment, what is it called as empirical treatment, CT scan of the chest, fiber optic bronchoscopy, or gene expert for mycobacteria from the sputum. Yes. Well, his chest X-ray showed a infiltrates in the lung. So although sputum was negative, there is a good possibility that if you obtain ball, you know ball, bronchial lavage, you see, it might be positive, you see. So you will do bronchoscopy here, fiber optic bronchoscopy to obtain the sample and then uh, see what can be done. Gene expert, of course, has no more values. We have already said Mentus was positive, so this will also be likely to be positive. Six-year-old boy complained of fever, cough, anorexia, and weight loss. Tuberculosis was suspected, and which one of the following investigations do you think will be most helpful? Mentus, ELISA, sputum smear, chest X-ray. Yes. Anybody? Will you do Mentus test? No, in a way, one is a 6-year-old boy. So he must have been vaccinated early, so that is likely to be positive. ELISA test, it is banned, available ही नहीं है. Sputum smear for acid fast bacilla. It's not there, and he's a 6-year-old child, so it will be difficult. So chest X-ray is all you can do, and just I mean, it is not again a definitive, but sometimes for diagnosis or treatment you have to resort to this thing. 36-year-old executive complained of mild degree fever, cough, breathlessness. Chest X-ray shows moderate degree of pleural effusion on the left side, but the lung parenchyma was normal on both sides. Tuberculosis was suspected as one of the likely diagnoses. Which one of the following investigations? Mentus, IGRA, sputum smear, pleural aspiration. B, D. Yes, of course you will, because there is a pleural effusion, and these of course Mentus and IGRA are almost same. Sputum is not available. ठीक है, so pleural aspiration is done, so you will do all the biochemical, cytological and microbiological investigations. 32-year-old housewife, loss of weight, dull abdominal pain, abdominal fullness, no fever, weakness, general fatigue, abdominal palpation with nodular and lumpy feeling, no definite mass could be found. Chest X-ray normal, plain abdomen X-ray showed a few fluid levels. Ultrasonography, there was nodularity and mesenteric lymphadenitis. No ascites. Barium enema showed thickened ileocecal valve and a thin string of the contrast pointing to a narrow segment of the gut. Tuberculin skin test was positive with about 15 mm duration. Most of the findings suggested intestinal tuberculosis. So morphologically, radiologically, they are all suggestive of tuberculosis, because there is nodular feeling, lumpy feeling, and fluid was there, lymphadenitis was there. तो confirm करने के लिए what will you do? Abdominal laparotomy, ultrasound guided aspiration, CT. Yes, obviously, of course, laparotomy would be more, but it is quite invasive and you will not like to. So lymph node aspiration, I think, is all which will be done. I think this is the last one. 28-year-old student feeling unwell, general fatigue, vague malaise, joint pains. No cough, sputum, feverish feeling, not a normal temperature, lymph node enlargement in the right supraclavicular and mandibular region. Routine hemogram, blood biochemistry, chest X-ray normal, tuberculin skin test positive. Fine needle aspiration from a large lymph node shows granulomatous lymphadenitis without any caseation. Staining for acid-fast bacilli was negative. Gene expert of lymph node aspirate was also negative. So what is the diagnosis here? Lymph node tuberculosis, sarcoidosis, lymphoma, fungal lymphadenitis. Sarcoidosis. So that basically differential diagnosis between sarcoidosis and lymph node tuberculosis. Now you see what is in favor of tuberculosis. That would be there even in sarcoidosis. This is the tuberculin skin test, you see. 10 mm duration, you see. Keep in mind that Mantoux test would be rarely positive in sarcoidosis. Most of the time it is negative. Although all other investigations could suggest that it is sarcoidosis, AFB were negative, gene expert were negative. But these are not always positive, you see. But so most likely it will be tuberculosis, you see, because Mantoux test is positive. Okay, thank you.
In extra-pulmonary tuberculosis, the role of ADA. Does the role of ADA, if a patient is having an accelerated pleural effusion and the cultures are coming out to be negative, and we have the ADA values very high, like 140, 150. So should we consider the TB as the most likely diagnosis, or other infections can also cause such a high ADA? In a long-standing infection, like a patient is complaining for 20-25 days with a similar complaints.
I think most likely it could be tubercular. Other infections don't cause this high level of ADA. That is one thing you see.
In some cases of empyema, we will be seeing ADA to be this much.
No. In empyema it does not rise that much, you see. So it's a kind of indirect marker, but good enough, you see. Most of the time you don't find other molecular tests or microbiological tests from the pleural fluid or from the other sites, you see, extra-pulmonary sites. So if it is high, ADA is a good evidence, you see. ठीक है. Okay जी, thank you.